let's go straight to the next one, which is about HIV-TB. We're not talking about now outbreaks, and this is why it's important to balance these two issues. One, epidemics, emergencies, and the other, endemic diseases. So our next speaker is Robin Wood, who is emeritus professor of medicine at the University of Cape Town, South Africa, and director of the Desmond Tutu HIV Center at the Institute of Infectious Disease and Molecular Medicine. Robin is an infectious disease physician. He gained his medical degree at Oxford University and completed his specialist medical training at the University of Cape Town, and he has published more than 450 scientific articles in these areas. Robin is going to talk about TB and HIV in South Africa. Robin, please.
Thank you very much. I'd like to thank the forum for inviting me. This is a picture of some obsolete TB infrastructure, which really is a measure probably of success in TB control in New York. It just leads into this comparison between New York and Cape Town. The slide has got somewhat scrambled, but essentially the slopes on the right-hand side show the age-adjusted TB rates in New York over 100 years. So you can see that it was a disease of the young and young adults, and now in the faint line at the bottom, it is a disease of old people, and the rates have come down. If you look on the left-hand side, which is Cape Town, you can see that things have changed very little, and over the last 80 years, that in fact the pale pink line, which is the top, shows that we have just as much TB as we had in children, but we've actually got more TB now amongst young adults, probably because of the HIV epidemic. So as you're aware, South Africa has an incredible burden of TB. It's probably the most highly burdened country in the world. And the town that I'm going to talk about is Cape Town. That one city has more TB notifications in 1 year than the United States of America, UK, France, and Canada added together. So we have a major problem. And one of the things that has always struck me is that the city has recognized this from the very earliest days. And you can see on the left-hand side here that TB was made a notifiable disease in Cape Town in 1904, just after the Boer War. And that was a decade before it became notifiable in the United Kingdom. So in fact, the point of this slide was to show that every advance in TB control measures had been temporaneously implemented in Cape Town, and yet we have this dreadful disease burden as at the moment. And this is really where we are with it. This is looking at a cross-sectional infection rates proportions in different age groups in Cape Town. And this is the majority population in Cape Town. You can see that by the time they go to school at the age of 5, 20% of them are infected. By the age of 14, 50% are infected. And by the time they reach young adulthood, most of them have either been infected or got disease. As I said, this was cross-sectional data. When we look prospectively at IGRA conversion rates, we finish up with even higher rates of up to 14% per annum amongst adolescents between 15 and 19. And that's been one of the groups and data that I've really struggled to try and understand. So let's just, it's a famous picture of airborne disease touched on by Professor Lee this morning, but essentially in the 1950s, Wells and Riley came up with this equation to describe the number of cases related to the number of susceptibles and some other factors. And that equation is valid for a steady state single transmission environment. But we've taken that and essentially tried to generalize it so that it's no longer steady state. and that it will take into consideration a multiple of factors which we think are driving our epidemic. And essentially, it comes down to three parts of the equation. The one is, we think as an airborne disease, the amount of volume of air that's swapped between individuals is probably a very key factor, and we think that that represents social mixing and the environment. We believe that the prevalence of TB amongst the population that you're looking at is going to be important, and that's really what the TB control program is trying to decrease prevalence by putting people onto effective therapy. And the last of the triad is something which I'm working on at the moment, which is trying to define the infectiousness of the range of TB cases. But we're going to look at social mixing in the environment, and I think Professor Lee touched on this, that carbon dioxide is often used as a way of measuring ventilation. So in this room, each of you is producing about 8 liters of 40,000 parts per million carbon dioxide every minute. So in this room, if we allowed the CO2 level to go up to 4,000 parts per million, it would mean that every breath that you were taking, 10% of it had been breathed out by somebody else. So it would allow you to calculate the amount of air that's been swapped. The equation looks complicated, but essentially the final steady state is defined by the production of everybody in this room divided by their per person ventilation. But the time we take to get to equilibrium is determined by this factor on the right, which says that if it's a very large room, it's going to take longer. If there's a lot of ventilation, it's going to take shorter. But the concept is that carbon dioxide disseminates very, very rapidly, and we believe that this behaves in much the same way as these small particles, 1 to 2 microns, which are the purported transmitters of mycobacterial TB. So we made this little gadget. It measures carbon dioxide continuously. It's linked to a GPS factor that tells us where the individuals with this, where they are, and we can download this information. So this allows an individual to travel through a variety of different environments, and for us to calculate the amount of air that's swapped between individuals in those environments. In case we're a bit worried about, well, where do we put the device? It turned out that it really wasn't very critical at all. This is my research assistant who strapped these devices to every part of his body and in the room as well. And in fact, they all track very well, showing that this is quite a good tracer gas, except for the red line, which is the one that's on his forehead. And there seems to be a little vortex that comes out of your mouth and increases the CO2 there. But if you put this into your pocket, you will get a very good reading, or if you have it on a lanyard around your neck. So just in case you're feeling smug, and this is only applicable to people living in the slums, this was a TB conference that I think had the name of Shared Air, and my research assistant took the device into the room, it's in Paris, and calculated that everybody in the room swapped 70 liters of air between themselves during the sessions. So just to show you how we use this, at the left-hand side here is the community I've been working in for about 20 years. It's, I thought it was pretty crowded. It has 25,000 people living on 1 square kilometre, but when I hear about Dakar, it doesn't sound quite as bad. But it's, by our standards, a very crowded place. This young lady walks in green to pick up a taxi, takes a taxi, changes a taxi, gets onto the yellow line and goes to a secondary school and carries one of these devices. And you can see that as she goes from classroom to classroom, that the carbon dioxide levels change dramatically. And just really to highlight the 2 classrooms that she spent time in, E and F, are quite interesting, because when she goes into the classroom, she's breathing the air from the previous people who were in the room. And you also see that you can't assume steady state, because they're not steady state, and they, during the time period, they don't reach steady state. So this is, shows that the ventilation rates are incredibly low. And when we tried to work out why those two classrooms were so bad compared to everything else, it was because they had windows on one side of the room and not on both sides, and all the others had cross flow. So we gave these devices to a large number of adolescents, because we're trying to focus on adolescents in this township of Masopumaleli. And this showed a difference between summer and winter. So we'll just go through here. Here's the liters of rebreathed air per day in summer on the left-hand side. And you can see that for these kids, the majority of the rebreathed air was in the house and in the school. And in the winter, they were breathing, on average, 150 liters per day, going up to about 300 liters per day. And the majority of that was whilst they were at school. I would guess that most of you probably rebreathe 25 liters a day. So that's just to put it into context. So we can use these devices throughout the township, and this shows where young people collect. One of the things we discovered is that young people have many more social contacts than most of us, and they tend to have lots of social contacts with people of their own age. We can then compare with the concentrations of CO2 and the locations for people who've just been diagnosed as having tuberculosis, people who've got over the acute sickness of tuberculosis and completed their therapy, and the adolescents. And this has always puzzled me in that they don't seem to overlap. So it means that the people that I'm recognizing as having TB don't appear to be the people who I am supposing infect the young people. So if you put that together, this is some work done by Jason Andrews, who works with us. He's at Stanford. And what this does is, for any given age group, it calculates the social models, the social mixing, and the CO2 levels of where the places are. And it gives you an idea that at any age where people are getting infected. So the first thing is it shows about 10 to 20% of transmission is taking place in the household. So it means that we have to look at other sites besides the household. The reason for that largely is because of the associative nature of households. You meet the same people every day in households, whereas when you go onto public transport or go into places with many more people, you have more generalized mixing. But the 15 to 19-year-olds, you can see that more than 50% in the yellow is transmission that we believe taking places in schools. So just a little bit of history here. I thought, well, let's look and see if anybody's ever measured CO2 in schools. And I found this study in the 1920s, and somebody in New York went through the schools and measured the carbon dioxide levels. And it was fascinating that they very rarely went above 1,000 parts per million. So they had these very high windows, which I think have ventilation driven by temperature gradients rather than our reliance nowadays on windows which require them to be open on both sides. So in 1920, they were doing the right thing. This is a paper from Santa Maurice. I've substituted put on the red line, which I believe is the steady state conditions, linking airflow rate, liters per person ventilation, against the CO2 concentration. And you see the factors that I was making, that here when airflow is high, you reach equilibrium very rapidly, but when airflow is low, you don't reach the equilibrium line, similar to the graph I showed you. But look at the levels, and these are schools in Europe and North America. And they're getting up to almost 4,000 parts per million, which means that during an 8-hour day, about 10%, so it's 40 liters, so it's about 300 liters of air is being rebreathed by people forcibly in schools. So if you look at the international recommendations for carbon dioxide levels in schools, is all around about 1,000, except for Portugal, which is 1,026, which I don't quite understand why they came up with that number, but everything else is around about 1,000. So quite interesting that we seem to have forgotten some really important lessons. So the model that I'm putting forward is that I believe that some of the major drivers of TB in our part of the world are air volumes exchanged. I also work in Polesmoor Prison, where people are locked up for 23 hours out of 24 hours a day with no ventilation, and they will be breathing 1,000 to 2,000 litres of other people's air per day. And I think this is a measure of the social mixing, and in those places they're very crowded and they swap the prisoners around, so it's a perfect environment for developing TB. I believe that the prevalence of TB transmitters in the population you're looking at is the major role of the TB control program to try and identify those. And I'm a little bit worried that when we identify them, we can't find them infecting the group of people who have the highest infection rates of up to 14%. So we need to work on that. And then another interesting thing which has been touched on with super spreaders, etc., is that when social circumstances are good and people are not rebreathing large amounts of air, then the only way you can get an outbreak is by having someone who's a super spreader. But the outbreak will not develop into endemic disease because the next generation won't be as infectious. Whereas I believe that part of the problem that we have is we have endemic TB, and I believe under those circumstances, the whole spectrum of infectiousness can transmit disease. Thank you very much for your attention.